All right, let's talk about something we do every single day at the pharmacy bench, counseling on acute pain. We're going to go through a practical guide here, really designed to sharpen our skills so that every patient interaction we have is as effective and safe as it can be.
So here's how we're going to break it down. We're basically going to follow the path of a patient walking up to the counter. We'll start with that all-important initial assessment. Then we'll walk through the medication options, talk about some special cases, and finally, we'll wrap it all up with a super handy checklist.
Okay, first things first, let's make sure we're all on the same page. We are talking specifically about acute pain. You know, that temporary pain that pops up and hopefully goes away. This isn't a deep dive into chronic pain management. Our goal here is quick, appropriate relief to help someone get through it.
And that leads us right to the most fundamental part of the whole process. You know it, it's the assessment. Everything we do, every recommendation we make, it's all built on this foundation. And it's way, way more than just asking, so on a scale of 1 to 10? A really solid pain investigation is actually a clear 4-step process. First, you just use your eyes. You observe their behavior. Are they agitated, anxious? Then you ask for that self-report with a pain scale. Step 3, you dig into their history. And step 4, and this is so important, you keep checking in to see how the treatment is actually working. And here is such a powerful way to think about it. We should be treating pain as a vital sign. I mean, think about that. We need to record a patient's pain score with the exact same seriousness as we would their blood pressure. It's not just some subjective complaint, it's a critical piece of clinical data.
Okay, so let's get into the medications. When we're talking about mild to moderate pain, maybe a patient says their pain is less than a 7, the first place we always go is to the non-opioids.
So when you're counseling, this is the key trade-off you need to explain, right? On one hand, you have NSAIDs, which are generally stronger and have that anti-inflammatory kick, but on the other hand, you have acetaminophen, which is often a much safer choice for a lot of people. And hey, don't forget to tell them they can often be used together for a bigger punch.
So when you're dispensing an NSAID, your counseling is absolutely crucial. You start with the easy one. Hey, always take this with some food. Then you've got to cover the more serious stuff, especially if they might use it long-term, like the risk of stomach bleeds and kidney issues. It's also our job to mention that small heart risk. And of course, to always ask that key question, are you sensitive to aspirin? Now, for that more moderate to severe pain, opioids are often on the table. And as soon as we start talking about opioids, well, our role as counselors just becomes 10 times more important.
And there's a good reason for that. The Institute for Safe Medication Practices actually calls opioids high alert medications. And that's a special label they save for drugs that have a really high risk of causing serious harm if they're not used exactly right. It's a pretty big deal.
Every single patient getting an opioid needs to hear this list from you. You have to be proactive, especially about constipation. It's practically guaranteed. You got to stress the sedation risk, do not drive or do anything that requires you to be alert until you know how this medicine affects you. And here's a great pro tip. Explaining that itching is usually just histamine release and not a true allergy can save a ton of panic. Okay, this right here is a massive counseling point. Not just for patients, but sometimes for prescribers too. Codeine is just, well, it's a wild card. Because of genetics, one person might get no relief at all, while the next person gets a dangerously high dose. Morphine, on the other hand, is the gold standard because it's predictable. It just works the way you expect it to. And while we're talking about drugs to be wary of, let's talk about mipridine. This should absolutely not be a go-to drug for acute pain. Why? Because it breaks down into a neurotoxic metabolite that can build up and literally cause seizures. There are just so many safer, better choices out there. Of course, things always get a little more complicated when we're advising special populations. And a super common question we get at the counter is about managing pain during pregnancy or while breastfeeding. So let's clear that up. Let's just break this down into the need-to-know points. Acetaminophen, it's your drug of choice, plain and simple. NSAIDs, there's a very specific rule. They absolutely have to be avoided after 20 weeks of pregnancy. Opioids can be an option, but it's all about monitoring the baby for any issues. And codeine, well, as we've already covered, it's just not recommended, period. All right, to pull all of this together and make it super practical, let's go over a final checklist. I want you to think of this as the core game plan for your very next patient consult about acute pain. So here it is. The goal is to make these 4 steps just automatic. Number 1, assess and document pain like it's a vital sign. 2, always start with non-opioids for that milder pain. 3, If you're dispensing an opioid, counseling on those key risks is absolutely non-negotiable. And 4, use your expertise to gently guide everyone away from those tricky drugs like codeine and mepridine.
So we've walked through the whole workflow, from the first question to the final safety check. We've hit the key decision points and the most critical messages. Now the real question is, for you, what's one thing, just one little tip from all this that you're going to apply in your very next patient consultation? Thanks for tuning in.